Welcome to the deep dive. Today we're diving into something that, well, it can be incredibly tough for anyone involved with breeding dogs or
Yeah,
cats.
premature labor. It's a really difficult topic.
Exactly. We've got some detailed source material here, and our mission today is to really unpack it.
Make sense of the complexities.
Yes. What it is, how you might spot it, wrestle with why it happens, which is often frustratingly unclear, actually.
Right, the unknowns are significant.
And then look at how it's diagnosed, what treatments might be on the table, and importantly, the kind of precautions and considerations involved.
And that's crucial because, as you said, pregnancy loss in a pet is just devastating. Understanding the science, even the gaps in our knowledge, is so important for owners and vets.
Okay, let's get started then. So first off, what exactly are we defining as premature labor here in dogs and cats based on this information?
So the source defines it as inappropriate myometrial activity that happens preterm.
Myometrial activity, uterine contractions.
Exactly. The muscles of the uterus contracting. And when that happens too early in the pregnancy, well, it can unfortunately lead to abortion, the loss of the pregnancy.
And preterm here means when?
Well, the source, particularly when discussing diagnostics like monitoring contractions, refers to preterm as being earlier than the 8th week of gestation.
Got it. So contractions kicking off before week 8. Is this more common in certain types of dogs or cats, specific breeds, ages?
Interestingly, no. According to this material, the siglement is simply a gravid female dog or cat. Gravid just meaning pregnant.
So any pregnant dog or cat could potentially experience this.
That's what the source indicates, yes. No specific age or breed predisposition mentioned.
Okay. So then how would someone even know this might be happening? What are the signs? You mentioned it can be difficult.
It really can be, especially early on. The signs can be, well, pretty subtle. Often there might be no obvious clinical signs at all.
Really? No signs.
Sometimes the very first clue might only be seen on an ultrasound, something called fetal resorption, where the fetuses are basically being reabsorbed by the mother's body.
Wow. Okay. What about later signs, if it progresses?
If it goes further, you might start to see vulvar discharge. The source specifies this could be hemorrhagic, so bloody, or what's called lochial discharge.
And I guess if there's a history, like if this has happened before without a clear reason.
Absolutely. That's highlighted as a key piece of the history. An unexplained loss of a previous pregnancy definitely raises suspicion.
Now, you mentioned the causes. This seems like something you desperately want to prevent, but the source material here basically says the causes are unknown with a capital U.
It's the central challenge. The primary point made is exactly that. The causes are unknown.
Oh.
Now, it does mention genetics can play a role sometimes, and the process, the mechanism, involves something called luteolysis.
Luteolysis, a breakdown of the corpus luteum, which makes the pregnancy hormone progesterone.
Precisely. That structure is vital for producing the progesterone needed to maintain the pregnancy. Its breakdown, luteolysis, is part of the process. But why it starts breaking down prematurely isn't always clear.
Is it a hormone problem that, like, not enough progesterone being made?
Well, that's suspected. Luteal insufficiency, where the corpus luteum isn't producing enough progesterone, is thought to potentially contribute. But the material is careful to note it's not actually documented as the primary cause in this specific context of idiopathic premature labor.
So wait, the source says the contractions start first?
Yes, that's a key point here. It states the inappropriate myometrial activity, the contractions, actually precedes the luteolysis, the drop in progesterone.
So the contractions trigger the hormone drop, not the other way around.
That seems to be the sequence described for this specific condition. And it's just, it's fascinating and frustrating that despite years of research, the initial trigger for those inappropriate contractions often remains a complete mystery.
Which makes treatment tricky, I imagine, if you don't know the why.
Exactly. How do you effectively prevent or treat something when the fundamental cause isn't understood? It puts a lot of pressure on diagnosis.
Right. Okay, so let's talk diagnosis. If a vet suspects this is happening, how do they figure it out, according to this source?
It's really a process of putting pieces together and ruling other things out. The first crucial step is what's called a differential diagnosis.
Meaning, check it's not something else.
Yes, you have to make sure it isn't just normal labor starting, right on time. Or that the pregnancy loss isn't due to something else entirely, like trauma, a toxin exposure, a developmental issue with the fetuses, or an infection.
Okay, eliminate the other possibilities. What about specific tests, blood work?
Routine labs like a CBC, blood chemistry, urinalysis are usually normal. You might see the expected mild anemia that often happens during pregnancy. That's normal.
Anything else?
Well, if there's significant bleeding or maybe inflammation involved, you could see changes like blood loss anemia or signs of inflammation in the white blood cell count. But the most critical lab test highlighted here is measuring serum progesterone.
Ah, the progesterone level. What's the magic number they're looking for?
This is really key. The source states the level will be less than 2 nanograms per milliliter.
Yeah.
That's 2 ngml when abortion is actually occurring.
Less than 2. That's the threshold.
That drop below 2 ngml indicates the pregnancy isn't being supported anymore. And importantly, the source stresses you need to use quantitative assays.
Quantitative, meaning very precise measurement.
Exactly. Methods like chemiluminescence or fluorescence immunoassay, they're needed to accurately measure those really low levels, specifically below 2.0 ngml.
Why is that so important? Can't other tests do it?
The rapid sort of semi-quantitative tests that are often available right in the clinic, they're noted as being least accurate in that critical range, between 2 and 5 ngml, so they might miss that crucial drop below 2.
Okay, so getting that precise progesterone number below 2 using the right kind of lab test is vital. What else? Imaging.
Ultrasound is definitely another essential tool. You can monitor the fetal heart rates.
Looking for signs of trouble?
Yes, fetal stress. Rates that are consistently below 170 beats per minute are a red flag. Ultrasound also lets you look for morphological changes, basically. Changes in the normal appearance of the uterus and the fetuses themselves, which can happen if fetal death occurs.
And you mentioned something earlier about monitoring contractions directly.
Right, that's Dakota anemometry. It's described here as being diagnostic.
How does that work? What are they looking for?
It directly monitors uterine contractions. Finding more than 0 to 2 contractions per hour is considered abnormal for a preterm gestation, again, defined in this context as earlier than the 8th week.
So you're combining things. Seeing abnormal contractions on the Dakota anemometry, confirming that progesterone level is critically low using a quantitative test, and maybe seeing signs of fetal stress on ultrasound.
Exactly. Because the outward signs can be so vague and the cause is unknown, the diagnosis really relies on piecing together the evidence from these specific tools, especially that quantitative progesterone and the uterine monitoring.
Okay, that makes sense. So let's say the diagnosis is confirmed. What does the source material say about treatment? What can actually be done?
Well, it first mentions some things borrowed from human medicine, like recommending strict rest or giving antibiotics.
Do those help?
Interestingly, the source notes that these approaches, while sometimes prescribed in vet med, don't actually contribute to a positive outcome in human premature labor studies.
Huh. Okay, so what is the main approach then?
The main strategy discussed involves using tocolytic agents.
Tocolytics. To coca, like contractions, tocolytic to stop, drugs to stop contraction.
Precisely. Their goal is to suppress or halt those inappropriate uterine contractions. The source lists a few classes: beta agonists, calcium channel blockers, magnesium sulfate, and prostaglandin synthetase inhibitors.
Are there specific drug names mentioned?
Yes, terbutaline is given as an example of a tocolytic. It's a beta agonist. The dosage suggested is 0.03 milligrams per kilogram, given by mouth every 6 to 12 hours, as needed.
As needed, meaning you adjust it.
Right. The idea is you titrate it, adjust the dose based on what you're seeing with the uterine monitoring, like the Dakota anemometry.
Okay, so try to stop the contractions with something like terbutaline. Is that the main thing?
That's one part. The other key group of medications mentioned are progestogen compounds.
Progestogens. So giving progesterone back.
Essentially, yes. These are forms of progesterone, often synthetic. And they come with some really significant caveats.
Okay, what are the options listed?
The source lists a few. Progesterone in oil, which is given as an injection, 2 milligrams per kilogram intramuscularly every 72 hours. Then there's Altrenagist, that's a synthetic one, brand name Regomate, actually manufactured for horses but used off-label here. The dose is 0.088 milligrams per kilogram orally, once a day. And also oral micronized progesterone capsules, like Premature. The dose there is 10 milligrams per kilogram orally once a day. But with the oral progesterone, it specifically mentions needing to monitor serum progesterone levels every 24 to 48 hours to potentially adjust that dose.
You mentioned caveats, though. Important considerations.
Yes, and this is absolutely critical, highlighted strongly in the source material. These progestogen compounds should only be used if that serum progesterone level has already been confirmed to be below the 2 ngml threshold.
Only if it's already dropped that low. Why?
Presumably because if progesterone levels are still adequate, adding more isn't addressing the primary issue, which might be the contractions themselves, and could introduce risks without benefit. And crucially, clients must be fully informed about the potential side effects before starting these treatments.
That sounds serious. Using these powerful hormones. What are the potential downsides or risks the source mentions, especially with the progestogens?
They list some significant ones. A major concern is prolonged gestation.
Going past the due date?
Exactly. This can happen if you don't withdraw the terbutaline or the progestogens 24 to 48 hours before the calculated due date. And that due date needs to be figured out accurately based on timing from the initial progesterone rise during the heat cycle or the LH peak or the first day of cytologic diestrus.
So timing is critical if you're aiming for a natural birth.
Very critical. Now, if an elective C-section is planned anyway, the source says you can continue the meds right up until the day of surgery. But for natural whelping, withdrawal timing is key.
What other risks? You mentioned side effects.
Another major one with progestogen compounds is poor lactation after birth.
Difficulty producing milk, why does that happen?
Because these external progestogens interfere with the normal hormonal cascade. Specifically, they inhibit the natural rise in prolactin, the main milk production hormone, which normally happens as the natural progesterone levels fall just before birth.
Wow. Okay, so problems with feeding the pups or kittens. Anything else?
Yes, another very serious risk mentioned is the potential for masculinization of female fetuses.
Masculinization. Affecting the development of female offspring in the womb. That's significant.
It's a major potential consequence listed for progestogen use during pregnancy. And there's one more big risk mentioned too.
What's that?
The risk of forcing the retention of what's called a pathologic pregnancy.
Meaning keeping a pregnancy that shouldn't be kept.
Essentially, yes.
Yes.
This is a concern if the initial diagnosis of idiopathic premature labor, meaning labor without a known cause, was actually wrong. If there was some other underlying problem like an infection or fetal abnormality causing the issue, using these drugs to stop labor could prevent the body from naturally expelling a non-viable or unhealthy pregnancy.
Okay, that really drives home why getting that initial diagnosis right, ruling out other causes, is so incredibly important.
Absolutely. Misdiagnosis followed by these treatments could lead to retaining a compromised pregnancy.
Given all these potential issues, what kind of follow-up and monitoring does the source recommend if treatment is started?
It recommends pretty intensive monitoring. Serial abdominal ultrasounds are needed.
To check on the fetuses.
Yes. Check their viability, heart rates. Look for any signs of distress or negative changes. Also, serial tachycardia anemometry, continuing to monitor those uterine contractions.
To see if the tocolytics are working.
Exactly. And specific fetal heart rate monitoring, using tools like Doppler or more advanced ultrasound modes.
So, quite a lot of ongoing checks. Why is all that necessary?
Well, for several key reasons. One, to see if the treatment is actually being effective at stopping the contractions. Two, to continually assess the health and well-being of the fetuses inside. And three, critically, to manage those risks we just talked about, especially knowing when it might be necessary to stop medication or intervene if fetal distress occurs or ensure timely withdrawal if planning a natural birth.
Right, constant vigilance, basically.
Pretty much. It's not a start treatment and hope for the best scenario. It requires close, ongoing management.
Wow. Okay. We have certainly covered a lot of ground today, really digging into the source material on canine and feline premature labor.
We really have.
We've defined it, those early contractions, talked about the signs, which can be surprisingly subtle early on, grappled with that big, frustrating unknown when it comes to causes, explored the diagnostic steps ruling things out, that crucial quantitative progesterone test needing to be under 2 ng/ml, using ultrasound, monitoring contractions with tachycardia anemometry.
Yeah, pulling all those pieces together.
And then we looked at treatments, the tocolytics like terbutaline to stop contractions, and the progestogens like progesterone or altranagest, but only if progesterone is already low and with those serious warnings.
The caveats are so important there.
Absolutely. Things like prolonged gestation, potentially poor lactation, even masculinization of female fetuses, and the need for intensive follow-up monitoring.
It's definitely a complex area of reproductive medicine.
Yeah.
And often very distressing for everyone involved. I hope breaking down this information gives you, our listeners, a clearer picture, whether you're directly involved in breeding or in veterinary practice or just interested in pet health.
Me too. And maybe a final thought to leave you with, drawing from everything we've discussed based on this source.
Yeah.
Consider this. The fact that the fundamental causes are still often unknown, coupled with the powerful nature of the drugs used for treatment and their potentially significant side effects, It really highlights the ongoing challenge in managing reproductive health for our dogs and cats. It underscores just how much more we need to learn and why continued research in this field is truly so important.